Hey everyone, it's Allison Winter. I'm one of the current interns. We are so excited to have you at Mount Carmel, and we are ready to hit the ground running with you in July. So as part of the Intern 101 podcast series, this is just a brief overview of a few things to keep in mind when getting a patient ready for the OR. These really aren't difficult concepts to grasp, but I think it's beneficial for you to hear them here first before you're expected to put in orders and actually help prepare a patient for the OR. So this is just a brief overview of the things that we'll be talking about during this podcast. First thing is first, NPO orders. So all of our surgical patients are kept NPO at midnight. There have been some updated reports by the American Society of Anesthesiologists on preoperative fasting. However, we prepare all of our patients, both general surgery and trauma, by keeping them nothing by mouth starting at midnight before their operation. A common oversight is to forget about tube feeds. A simple communication order and a follow-up phone call to the nursing staff is typically sufficient for holding tube feeds appropriately. In order to optimize hydration status prior to undergoing general anesthesia and a surgical intervention, fluids are typically ordered. These can be timed to start at the time of NPO status. So if a patient is eating throughout the day and then made NPO at midnight, you can start IV fluids at midnight. A general consideration should be made towards dextrose-containing fluids when a patient is NPO. However, there will be situations like neurosurgical patients who should not receive dextrose. The culprit of a lot of nursing questions in our pre-op patients is a patient's med list, particularly when most of the medications are PO and the patient is now NPO in preparation for surgery. A few general concepts include holding blood thinners, whether it's aspirin, Plavix, Coumadin, Eliquis, etc. There will, of course, be scenarios and patients where the risk of stopping the thinner is greater than the benefit of stopping it. So just keep that in mind, but in general, stopping them is, what we typically do. So when in doubt, always ask a senior or you're attending. As far as antihypertensives go, ACEs and ARBs are held on the day of surgery. This is mostly due to a risk of hypotension with anesthesia. And then on the flip side, beta blockers are continued for their proven benefit for several things. One, to reduce myocardial oxygen demand, control arrhythmias, and also, and importantly, prevent withdrawal in those who are chronically beta blocked, which withdrawal in the patient who is chronically under beta blockade can lead to substantial morbidity and mortality. Recently, I've been fielding several pages regarding insulin orders. So there are patients who will be on a long-acting insulin at night, and the general rule is to give half of the dose of long-acting the night before surgery rather than the full dose. And that's just simply for the fact that they'll be NPO. As far as short-acting insulin goes, I think most of us use a sliding scale insulin, which doesn't really change what we do for insulin administration on the morning of surgery. So if they get a glucose check and they're hyperglycemic, they'll just follow protocol to give the appropriate amount of insulin. As far as prophylactic antibiotics go, prophylactic antibiotics to be given on call to the OR is not always as straightforward as one would think, but fortunately there are great guidelines on up-to-date, and also in Power Chart we have a few power plans that guide us in helping choose the right antibiotic most appropriate for the surgery that we're doing. So here is kind of a blurry snapshot of the pre-op power plan for the gastric, biliary, and bowel surgery. It says order cefazolin and metronidazole except for biliary tract, non-obstructed small intestine, and hernia procedures. So in those procedures, you would order cefazolin only. And then, as you can see, there are several boxes below for different antibiotic choices, and then there are drop-down arrows that allow you to make dosing adjustments. So when it comes to heparin or Lovenox in the perioperative period, the general rule of thumb is to continue heparin or Lovenox injections if they are prophylactic dosing. And that's key. So continue prophylactic heparin or Lovenox, but hold therapeutic dosing. Same thing typically goes for resuming them on the day of surgery, but just keep a few things in mind, like the type of surgery and your intraoperative blood loss, etc., before you resume the thinner. Again, when in doubt, ask your senior or your attending. A few other miscellaneous things to think about are labs, particularly coagulation panels and types and cross. The coags are particularly important in someone who is already on a thinner and you anticipate a coagulopathy that might need reversal with vitamin K or FFP or platelets or whatever it might be. And a type in screen or a type in cross becomes important in operative cases with anticipated blood loss. Something that we don't see a whole lot of or don't put in too many orders for is medical clearance for risk stratification prior to going to surgery. Often you'll see this done in an outpatient setting, or actually we see this in several of our trauma patients who are undergoing orthopedic or neurosurgical intervention. But you'll hold discussions with your attending on whether or not additional testing is needed, or if a medical or a medicine consult is warranted. So an important step in discussion of surgery with your patient is explaining the risks, benefits, and alternatives to the case. This is followed by a consent form that states that the patient has had this discussion with you and that the shared decision was made to proceed with surgery and that they understand the risks, etc. So an order can be placed in a chart for this, and it is named consent confirmed and witnessed as present. So what this does is it allows the nursing staff to get the paperwork started and be ready for the surgeon to sign. So it's important to note here that residents are unable to sign consent forms for OR cases, but they can sign for bedside procedures like central lines. So bottom line there is hold those discussions with your patient, get the paperwork ready, but you are unable to sign as the surgeon. And then last but not least, don't forget to call the OR front desk to get the case on the schedule. So they will always ask what the surgeon's availability is, so don't forget to ask the attending. So these are just a few things that I think about when closing skin during a case or getting a patient transferred to the PACU. It's not all encompassing, but just a few things you'll want to think about as you place your post-op orders. So is my diet changing? Do I still need IV fluids, or can I HEP lock them when they're tolerating fluids? What do I need to do with their home medication list? Do I need to resume anything? DVT prophylaxis, as we talked about, typically continued if prophylactic dosing, but let's say you have significant blood loss during the case that wasn't expected, the attending may want to hold for 24 hours before resuming. And then things like lines, tubes, and Foley. So if a Foley is put in during the case, should it stay in or should it come out? If it should stay in, should it anticipate coming out in 24 hours, etc. And then simple things like wound and dressing care. Those are easy orders to place that will prevent several phone calls. And then, of course, disposition planning. So is this patient going home from the PACU, or do they need a bed? And if they need a bed, what do I need to do to facilitate that? So that's all I have. As I mentioned in the beginning, these are just a few general things to think about when your senior or your attending says, hey, can you get this patient pre-opt? I personally had no idea what that meant, and so I hope this is helpful and is just a good start for thinking about what needs to be done when getting a patient ready for the OR. So again, hope this helps, and we look forward to seeing you in just a few short weeks.